right. Hello, everyone. Thank you so much for joining us. My name is Megan. I am serving today as a volunteer of the Epilepsy Foundation and really excited to be with you all. Before I introduce our speakers, I just want to be sure to acknowledge our sponsors from today's symposium. Thanks for Charlotte's Web, Jazz Pharmaceuticals, SK Life Sciences for their gold sponsorship of today's event. Now I get to introduce the speaker for this talk. Dr. Strom is an associate professor of neurology at the University of Colorado, fellowship trained and specialized in the care and management of patients with epilepsy and non-epileptic seizures. She holds a secondary appointment in the Department of Psychiatry and has over 15 years of experience leading clinical trials for epilepsy, examining anti-seizure medications, and since 2016 has focused her research efforts on examining the effect of functional neurological disorder, also known as non-epileptic seizures, and on the reduction of seizures and healthcare utilizations for those patients. She pioneered a comprehensive treatment clinic for patients with NES in the Rocky Mountain region and received the University of Colorado Medical Staff Pioneer Award in 2019 for these efforts. This multidisciplinary treatment clinic has delivered care to 1,000 NES patients since 2016, and she receives financial support in line with Medicaid expansion underneath the Affordable Care Act. She's a member of the board of directors of the Epilepsy Foundation of Colorado and currently serving on the employment committee. Welcome, Dr. Strom.
Okay, thank you for that kind introduction, which I actually wrote myself. Somebody always told me start with a joke, but it's not a joke. It's the real deal. So I was asked to give this talk, and I'm afraid in the agenda it actually just says comorbidities in epilepsy. And if you think psychiatric comorbidities might be a broad topic, comorbidities would just be impossible to give in a 45-minute presentation. So I'm confining this to psychiatric comorbidities and want you to know that Dr. Woodward and I and Dr. Dries are writing a chapter for an encyclopedia on this particular topic. So I'm gonna click a button here. How does this work? Oh, this is it. Oh, see, the forward arrow is so used, you can't see it. Okay, word to the wise there, guys. Okay, so conflicts of interest, not really a conflict, but an acknowledgement that these slides are courtesy of Dr. Dries and Dr. Casino. We presented this topic at the American Academy of Neurology this past week. I want to discuss the prevalence and causes of mood disorders and their complications in epilepsy, in patients with epilepsy, and also identify some features for neurologists who may not know, and look at some assessment tools for actually defining the diagnoses, as well as talking about some therapeutic approaches and the mood changes, very briefly, the mood changes that can occur after seizures. So just to frame this, to remind you, epilepsy is very common globally. We have 65 million people with epilepsy. And in the US, that translates into 3.4 million patients with epilepsy. So 1 in 26 people have epilepsy. It's a big number. And 6 out of 10 of those, even with genetic testing and everything we know now, we really don't know the cause of the epilepsy. And we're spending a lot of money treating it, $12.5 billion US per year, and we do have early and effective therapy. So I guess the question you might have is, why are we talking about mood disorders that accompany epilepsy? And I think that the biggest ticket item here is that these changes in mood actually lead to other adverse events for our patients with epilepsy. Injury and trauma. Imagine a person who runs after a seizure and isn't capable of sort of governing where they want to go. I had a patient walk out of a window after a seizure. So it's important. Status epilepticus is where seizures won't stop. That can be very dangerous to the patient. And the shocking statistic, and these are from the Epilepsy Network Facts website, is that 25 to 50,000 people die of seizures or related causes every year. And then there's sudden unexpected death in epilepsy, which we'll touch on a little bit. And these injuries that people get are anything from drowning to car accidents if they happen to be driving while they're having a seizure, cardiac arrhythmias, fractures, oral injury, which are very painful. Mostly the side of the tongue gets bitten. And psychiatric comorbidities in epilepsy are really very common. They also are similarly common in other chronic neurological disease. For instance, multiple sclerosis is one. And there seems to be a prevalence for types of epilepsy to have mood disorders, specifically temporal lobe epilepsy. And these numbers are a big range, 20 to 80%, and we'll touch on why that is in another slide. But other focal epilepsies is also up there at 54%. And then generalized epilepsy, like juvenile myoclonic and those kinds of things are actually pretty low with psychiatric comorbidity. So if you're talking about depression, bipolar, and other hypomania, I'd like to just point out that if you look at the general population prevalence, we've got, this isn't incidence like how often are people getting it, but general population is 8.2%, and in people with epilepsy, it's 22.9 to 23.6% for depression. These are really big numbers. It happens more in people with epilepsy. And then the anxiety disorders in general, also much higher, although the general population has a range that encompasses the average in epilepsy. And then mood and anxiety disorders are higher as well with people who have epilepsy. And unfortunately, and these are the really scary numbers, is suicidal ideation attempts and completions are much higher in the epileptic population. Psychosis is higher, not as stunningly, high as you see in the other disorders. So again, why does it matter? Well, these mood disorders explain the greater variance in health-related quality of life. And they are irrespective of the seizure type, frequency, or level of control. In other words, you can have the mood disorder whether your seizures are controlled or not. And yeah, the other fun fact is that I was in Boston this week trying to make this slide set on a Mac. I don't know if there's a lot of Mac fans out there, but PowerPoint for Mac doesn't work very well. Anyway, there is basically, or maybe this isn't the correct slide set. Yeah, I don't think it is. That's okay. There'll be more interesting unformatted slides in the future. There's a bidirectional relationship between epilepsy and depression. In other words, people who have depression are at a higher risk of developing epilepsy. Likewise, people with epilepsy are at higher risk of developing depression. And we think this is probably a combination of factors. It's not really known why, but maybe the anti-seizure medicines have something to do with it. They do, after all, work on the brain. And then other neurophysiological changes and psychosocial challenges that come with epilepsy. So the symptoms of depression, this was an interesting talk because we gave it to a room full of neurologists and they're all saying, why? I'm a neurologist. I'm not a psychiatrist. And why should I be doing this? Well, the truth is so many people with epilepsy have depression. We really should know how to do it, and we're capable of it. We're physicians, and we can do this. The symptoms of depression are usually severe enough to cause noticeable problems for patients, and you can ask about them. Does the patient feel sad? Are they feeling worthless or guilty? Are they having a change in their appetite, either eating too much or not eating enough, not having any appetite? Are they sleeping too much or are they not sleeping at all? Do they have fatigue or low energy? Can they concentrate? Are they feeling like their movements are slow, like they're walking through mud? And these are the SIGI-CAPS criteria that we've all been taught in medical school, and they pertain. If you have major depression, you have to have 5 or more of those, having lasted for more than a couple of weeks. And if you have a persistent, what we call persistent depressive disorder or dysthymia, you can have 2 or more of them lasting for 2 years. And so what's the prevalence in epilepsy versus the general population? Again, it's 23%, and it's independent of how you ask the patient. In other words, studies have run the gamut between, people using a specific device, which I'll talk about, to structurally interview the patient, or just getting a clinical sense whether the patient has depression or not. And why is this being researched at all? Well, there are guidelines for therapy, which we'll talk about, and neurologists can assess this, and they should assess it and treat it. Oh, this is not the right slideshow. Damn it. Oh, what happened? Did I turn it off? I think I turned it off. Okay, I know what I'm doing. Bipolar disorder is more difficult to diagnose, probably for the neurologist especially, because you can diagnose bipolar 1 if a person has had one lifetime manic episode. But often patients don't report those, they just report the mood disorder that they have. Bipolar 2, you've had to have one lifetime hypomanic episode, and both of these along with major depression. And cyclothymic, where you're hypomanic and depressive, part of the time. So it's common to fail to diagnose bipolar disorder. And in my line of work, it also seems to be too common. We undiagnose bipolar a lot in the non-epileptic seizure clinic. But in general, studies show that it's not diagnosed in as many people as it should be. 40% of patients are initially diagnosed with unipolar depression. And it's important because they're more resistant. The disease, bipolar disorder, is more resistant to pharmacotherapy. And they need early, referral to a psychiatrist who can manage that. So you might say, well, what are the symptoms of mania? It might seem like a really obvious question, but apparently for at least neurologists, it's a little bit challenging. The changes that you're having that are manic have to be occurring for at least a week and really affect your functioning. Like you're talking too much, you have rapid speech, you're distractible, you don't want to, you don't think you need to sleep. You're agitated, you have an expansive mood, you can be grandiose. Your mood is labile, in other words, very unregulated. You can be very depressed or very happy, and kind of all over the map. And in really severe cases, hallucinations and delusions can occur. And hypomania has to last for 4 days, and it doesn't cause the major deficit that manic symptoms do. So what are the epilepsy-specific psychiatric disorders? Well, there's the often described periictal dysphoric symptoms and syndrome, and the Geschwin syndrome, and the interictal dysphoric syndrome. And the bottom line is these are old terms and old studies. And I think that I won't go into the hairy details, but a lot of these things were described before we knew a lot about what epilepsy does to people. And they are artifact of old ideas. And we're going to highlight that in our chapter. So generalized anxiety disorders seem to be underreported in epilepsy. And those include excessive anxiety for more than 6 months that interferes with daily functioning. And the prevalence is really variable. If you use a structured interview, like the GAD-7, which we'll just touch on briefly, 27.3% is what you'll measure. But if you just try to get a clinical idea of whether somebody is anxious, the number is really low. And if you look at the studies that are in the reference section, you can see that. Phobias don't seem to be a big ticket problem. And then panic disorder, which is basically an unexpected surge of fear that takes over, peaks in a minute or so and then goes away, but then leads to worry about it happening again for about a month. And so once you get those things diagnosed, you can diagnose panic disorder. And the problem with diagnosing these disorders seems to be that they have a prevalence with drug-resistant epilepsy, so some studies may not include that population. And it seems to depend on what the recruitment, like where you define this, whether it's outpatient or inpatient. And then the onset of epilepsy and the duration seem to affect this number as well. More interesting formatting. Okay. So mood and anxiety disorders associated with suicidality are independent of epilepsy. And we talked about the bidirectional effect. So mood disorder and epilepsy seem to precede one another in a bidirectional fashion. And the suicidality with epilepsy is really, I would say, sky high. And bipolar disorder and panic disorder have the strongest association with suicide attempts. Sorry, panic disorder. And less so with major depressive disorder and agoraphobia. So 11.5 of deaths with persons with epilepsy by suicide compared to 1.6 in the general population. I don't know how you feel about it, but that seems staggering to me. Most studies support a rate of suicide that's increased in epilepsy. This is a standardized mortality ratio of 3.49, more, likely to have suicidal ideation and attempts than the general population. And fortunately, these numbers seem to be dropping since the 1970s. And that's probably because we, from the 1970s to now have better treatments for depression and panic and anxiety than we used to have. And there is a decreased standardized mortality ratio in the developmental disability category. People with epilepsy and developmental disability don't seem to have the large numbers of suicide. And looking at some of the studies, it's a little hard to tell exactly why that is, except that I think a lot of people who are developmentally disabled are actually being cared for by others. And so they don't have the access to and the planning capability of trying to commit suicide. So there are some drugs, and this was two Canner studies looking at whether depressive symptoms are made worse by certain drugs, and that can be the case. We all know levetiracetam is very guilty, and we hope that brivaracetam wasn't, but turns out it is. And then topiramate and zonisamide cause a lot of speech problems, but these others, felvital, tiagabine, and barbiturates, can also cause depression. And neutral, they think, are phenytoin, lacosamide, rufinamide, and cannabidiol. But potentially there are some drugs that actually improve symptoms of depression and anxiety. And those include carbamazepine, which I think the molecule was being investigated initially for the treatment of depression. It's a heterocyclic compound. And then Depakote lamictal, which I think is overemphasized. If you look at the literature, it has a very modest effect on depression. And then gabapentin and pregabalin and benzodiazepines are pretty good for anxiety disorders. So the problem with this, though, is that the effect on mood is not very predictable. More formatting. Okay. And it doesn't seem to be any difference in the type of seizure medicine prescribed in the patient with and without psychopathology. So we know about levetiracetam and perampanel causing aggressiveness and irritability. I usually don't ask patients, are you depressed on the drug? I usually say, is your spouse or your loved one irritated with the way you're acting? And that's usually the symptom that patients will complain about. But there are also enzyme-inducing anti-seizure drugs that can reduce SSRIs. It doesn't seem like in the literature that that's clinically relevant. But we also know that SSRIs are, have some efficacy in treating seizures in some animal studies. So what are the effects of surgery on mood? Postoperatively, psychiatric disorders can occur somewhere between 9 and 58%, depending on which literature you're looking at. And we're talking about basically the person didn't have a psychiatric disturbance before the surgery and they have one afterward. And it's more likely, as we had already mentioned, with temporal lobe resection being more likely to cause mood problems and probably occurring in the first 6 to 12 months post-op. And those are people who have risks for this to occur are folks who've had pre-surgical depression, a history of interictal psychosis, older age at surgery, and contralateral epileptiform discharges, and then also being on levetiracetam. So what happens here? Why do people get this problem? Well, a lot of it in the immediate post-op period is caused by steroids and narcotics. Makes everybody confused and they don't behave the way they normally behave. So the solution there is to take that medicine away and the patient will get better. And then again, also if it's temporal lobe resection. And other events during the postoperative period can cause mood disturbance like swelling or stroke, and also non-epileptic seizures, which we'll talk briefly about. So post-op psychiatric symptoms and their diagnoses. So the data from multiple studies show that we've got TLE with, sorry, there's so many acronyms in here, which I had all taken out of in the other slide set. Temporal lobe epilepsy and mesial temporal sclerosis. People became seizure-free in spite of these disturbances to a great degree. And so it doesn't seem to affect the outcome of surgery. And 3.9% of post-surgical patients in a large, isn't really a large study, it's a fairly small study, N of 27, showed an association with full-scale IQ being less than 80 to develop non-epileptic seizures after surgery, as well as having a preoperative psychiatric diagnosis. And up in concert with the NES data that Dr. Woodward will talk about, mostly female, and seizure onset after adolescence is a risk factor. So I'm going to have to skip through some of these slides because I'm not going fast enough, which is other news flash atypical for me. I usually talk like very quickly. So, I want to emphasize, as Dr. Dries did, that any practitioner can assess symptoms of depression and assess the severity of the depression. There's a simple bedside tool. It's called, getting the SIGI CAPS criteria, and there's a few others. And psychotic depression probably should have an urgent treatment with an antipsychotic and also a referral to psychiatry. So how do you do a psychiatric assessment? We recently wrote an article and one of our colleagues had put in the phrase, diagnose and adios. That's a terrible, terrible thing to say. But a lot of neurologists really don't consider it their job. But I argue, as did Dr. Dries, that you should ask about feelings of depression and anxiety because it has an impact on the patient, on their wellness, on their quality of life, and in fact, on their seizures. So I'd like you to consider a formalized approach. There's many tools. They're all available on Epic. If you don't have that, they're all available online. And that's the Neurological Disorders Depression Index in Epilepsy, which has the advantage of not asking questions in a way that you'll get confused about the side effects of seizure medicines or the side effects of seizures themselves. And then the patient health questionnaire, the 2 is just really quick. And we do that in our clinic to every patient and then go on to the 9 if they have any symptoms that are positive. Beck's depression inventory takes a little bit more time, as well as the Hamilton depression rating. And the GAD-7 is only a 7 question questionnaire, so they're really quite easy to give. And they're designed to, find out right away if there's a problem. So the questions on the NITI are, is everything a struggle? And do you feel like nothing you do is right? Or do you feel guilty or you'd be better off dead? Or do you feel frustrated and have difficulty finding pleasure in things? And then a cutoff score of 11, more than 11 suggests major depression. And the PHQ-9, the first 2 bulleted, highlighted, little interest or pleasure in doing things, feeling down, depressed, or hopeless. And if you have those symptoms, they go on to give a more complete. GAD-7, again, is very brief. Are you feeling nervous or anxious? Anybody can ask these questions. You can give it to the patient asynchronously in the waiting room. You can have your medical record push it out to them so they can answer it online. And what are the treatment considerations? Well, we can, treat a lot of mood disorder with anti-seizure drugs. And those, you can also ask yourself if the anti-seizure drug is causing, like in that one bullet, causing the mood disturbance. And depression is treated with serotonin reuptake inhibitors and SNRIs as well. Psychotherapy and working on coping skills, a referral to a psychiatrist is probably necessary, or a psychologist or some other therapist. And then augmenting with the ILAE, that's the International League Against Epilepsy guidelines. Anxiety, again, SSRIs and SNRIs in psychotherapy. We also use gabapentin and pregabalin. The psychiatrists in our clinic use a lot of that. That seems to be quite effective. And as it's always really surprised me, but antihistamines is on that list as well. Benzodiazepines, as you know, can be habituating. So we try to only use those in the acute phase. And then psychosis, obviously, and we'll talk a little bit about whether we have to worry about this causing problems with worsening seizures. And then epilepsy surgery. I mean, honestly, if you can stop their seizures, then mood problems get better. So ILAE treatment recommendations, the X stands for yes, this is check. So if you've got mild, moderate, and severe depression, SSRIs and NSRIs, as I discussed, and you don't have to worry about them worsening seizures. I know this is a question I get from primary care doctors all the time. Can I give them, because there's literature to suggest that maybe that's a problem, and it really doesn't hold true. And then obviously therapy, yes, give that to people with mild. And in fact, there's some literature to suggest you don't need a medicine in a person with mild depression. And then if they have moderate, yes, do it, but also give meds as well as with severe. And again, CBT and therapy isn't going to worsen people's seizures, might worsen their non-epileptic seizures. And Dr. Woodward will talk about that. And then augment with mirtazapine or neuroleptics if it's needed, add lithium. And I think this is the period of time where the neurologist is going to be saying, we're in the moderate to severe, and we want to refer you to a psychiatrist for definitive management. And then vagus nerve stimulator is also got a check mark for severe depression, but the parameters haven't really been defined as well as we would like. And then transcranial magnetic stimulation has some evidence as well and does not worsen seizures. So what happens to a patient? How am I doing for time? Okay. What happens to the patient after a seizure? Because this is an issue as well. And we cope with this in the epilepsy monitoring unit all the time. Patient is a runner, or they get post-ictally psychotic, or they get aggressive after their seizure. And Dr. Cascino showed some absolutely terrifying videos of just how profound this can be. What are the post-ictal behavioral change risk factors? Again, it's focal epilepsy. So there's a part of the brain that isn't functioning properly, but it's uncommon in the idiopathic generalized epilepsy, just as we talked about. So it's the same kind of risk factors for post-ictal behavioral changes as well as for mood changes that are associated with epilepsy. And it's also seen more in the chronic patient rather than the person who's just had recent onset. And then if a person has bilateral temporal lobe epilepsy, and I think of this as the brain is not just hurt on one side, it's hurt in more than one place. That's a risk factor as well for post-ictal changes. And any history of having had post-ictal psychosis before is a risk factor for independent post-ictal behavioral changes other than psychosis. Any history of anxiety is going to increase the risk, and a family history of mood disorders, which makes sense. And then some immediate factors, and I found this in my practice all the time. If a person has clusters of seizures, they're more likely, if they have post-ictal psychosis or behavioral changes, they have a tendency to have more if they have many seizures at once. And then in the EMU, if you have a generalized tonic-clonic seizure where you're convulsing, that increases the risk of behavioral changes. And then prolonged seizures as well. So the prevalence of post-ictal psychiatric disturbance was looked at by Dr. Canner in a group of 100 patients, and cognitive symptoms topped the list. Neurovegetative symptoms, meaning the patient is just sort of out of it afterward, was second only to that. And these people, obviously, this adds up to more than 100. So people have more than one of the problems that are listed here. And then symptoms of depression and, being very, very tired, somnolence, and trouble with frustration tolerance, and feelings of self-deprecation, crying bouts, hopelessness, feelings of guilt, and all the way down to psychotic symptoms, which you'll see is really the smallest, the least prevalent. So really the things that we see mostly in the epilepsy monitoring unit are actually agitation, delirium, and psychosis after generalized tonic-clonic seizures. And fortunately, 60% of this resolves within 1 week and 95% within 1 month. So the prognosis is very good. Up to 50% recurrence rate though. So again, like we said, the risk for having one is having had it before. And then 13 to 39% of people develop interictal psychosis, which is another number that kind of stunned me a bit. And 2 or more episodes predisposed to new onset interictal psychopathology. So if you've had it a couple of times, then you're in that queue where you may develop the problem in between seizures and then have to be treated for that. So like I said, there doesn't seem to be any impact on epilepsy surgery seizure freedom or the cognitive outcomes after a surgery. So that's good news. And there's a higher risk for serious depression following epilepsy surgery, specifically left temporal lobe. So I hope I've convinced you that mood and anxiety disorders are common comorbidities in people with epilepsy, and that there's a high prevalence early after diagnosis, later in the course, as well as in patients with drug-resistant epilepsy, and that mood and anxiety disorders are underdiagnosed and undertreated. And clinicians can be good at evaluating patients for depression, anxiety, and bipolar disorders. A little less convinced of the bipolar disorder part, but I think that we've at least got the tools to make a start on that. And that there are short questionnaires that you can use in the clinic to aid you in making these diagnoses correctly. And that if these mood problems go untreated, that has a negative impact on the quality of life and the seizure control and healthcare utilization of these individuals. And your medical treatment or referral to psychiatry with or without psychotherapy can make a huge difference in the lives of patients with mood disorders and epilepsy. So that is that.